CD, Professor of Cardiology, London Medical College, Kannur. I invite Dr. Ramakrishna to come next. And he is speaking on pre-operative cardiac evaluation for non-cardiac surgery. Introduction of the guest speaker by Dr. Prasad.
Good evening, everyone. It's my pleasure to introduce Dr. Ramakrishna CD. Sir completed, Dr. Ramakrishna completed MBBS from Government Medical College, Calicut in 1995, and he did his MD from Medical College, Kottayam in 2001. And he finished DMB in General Medicine in 2002. And after that, he did his DM in Cardiology from GMC Kottayam again in 2007. And he joined Medical College Pariyaram, Government Medical College Pariyaram in 2009, and he is presently working as a Professor of Cardiology and Unit Second Chief. So we have a very important topic today, preoperative cardiac evaluation in non-cardiac surgery, especially because it's beneficial for both surgeons and physicians. So let's wait for a very interesting session. Thank you.
Good evening, all of you. At the outset, let me thank IMA Office Manager, Kannur IM branch, as well as Dr. Manu Matthews for inviting me to deliver the lecture today. Dr. Manu has given 3 topics to me, but I selected this topic, that is the preoperative cardiac evaluation for non-cardiac surgery, because I think this is the most relevant topic for all of us. Most of us, especially physicians, anesthesiologists, orthopedicians, surgeons, gynecologists, because in day-to-day practice, we see a lot of patients for cardiac fitness for non-cardiac surgery. So I thought this may be the relevant topic for the discussion. And in my residents, they usually in afternoon OPD, they see a lot of patients for the cardiac fitness. From all the departments, we receive patients for cardiac fitness. So coming to preoperative cardiac evaluation for non-cardiac surgery. So cardiac complication, especially there is a perioperative myocardial infarction, what we call PMI, perioperative myocardial infarction, or myocardial injury of non-cardiac surgery, MINS, are major cause of post-operative morbidity as well as mortality in surgical patients. Myocardial ischemia with or without myocardial infarction, maybe mild myocardial ischemia or maybe myocardial infarction, it's a common and feared cardiac complication for non-cardiac surgery. And inpatient mortality, if patient develop this complication, inpatient mortality is the range of 5 to 17%. Based on POISE 1 and 2 trials, they have shown that there is a range is around 5.8 overall risk of post-operative major cardiac complication in patient undergoing either major or minor non-cardiac surgical procedures. So what is the pathogenesis? Because actually patient going for surgery, there may be stress. Patient may be under stress. So there is a release of sympathetic overactivity, then catecholamine release. All this results in increased oxygen demand. So increased heart rate, blood pressure, increased myocardial oxygen demand, and plaque rupture or vascular injury. All these results in myocardial. This is the pathogenesis. So all because of stress, increased heart rate, blood pressure, and also increased oxygen. All this results in the myocardial ischemia and maybe myocardial infarction. And we have some treatment modalities which can block this, can prevent this pathogenesis. So risk of perioperative cardiac complication depends on, there are 2 factors. One, patient-related risk factor. The risk factor because from the patient side, or risk of operation. So patient-related risk factors like end-organ cardiovascular disease, or its equivalents like coronary disease, heart failure, severe valvular heart disease, severe arrhythmias, or atherosclerotic vascular disease, peripheral vascular disease, stroke, history of CVA, chronic hypertension, chronic kidney disease, history of the uncontrolled diabetes, advanced age. All these and may the patient-related factors. They are because of patient-related factors. Then, so some condition, cardiac condition, their patient should undergo evaluation for prior to non-cardiac surgery, especially patient with history of angina, patient history of unstable coronary syndromes, and ongoing chest pain or history of previous history of coronary disease, and heart failure, decompensated heart failure, history of arrhythmias, any significant arrhythmia, heart blocks, or history of ventricular tachycardia or atrial arrhythmia syndrome. And severe valvular disease, like especially severe mitral stenosis, aortic stenosis syndrome. Or if there is history, definitely he has to undergo preoperative cardiac evaluation. So coming to surgery. So what are the surgeries which carries high risk? Especially surgery, prolonged surgery. Patient going for prolonged surgery, whether it extensive blood loss, large volume fluid shift, or abrupt change in afterload. These are the major surgeries that we have to anticipate, and patient should do the evaluation. The major vascular surgery, one of the surgery which carries highest risk is vascular, so that is abdominal aortic aneurysm repair. Any aortic aneurysm repair is the surgery carries highest risk. Then any surgery, emergency surgery, definitely it carries high risk. So any emergency surgery risk is high. Some minimally invasive operations like endoscopic procedures, some skin procedures or eye cataract surgery are usually very low. Sometimes that evaluation may not be required because you can straight away take up the patient for surgery. So surgery, based on the surgery, we can risk stratify like low risk, like risk is that 30 days and that major adverse cardiac events are less than 1% if breast surgery, dental procedures, endocrine procedures, cataract surgeries, some gynecological procedures and all, minor surgeries. That's a low risk. Intermediate risk is 1 to 5% for developing cardiac complication at the end of 30 days. Abdominal surgeries, carotid surgery, peripheral vascular surgeries, some endovascular procedures, then head and neck surgeries. So there are some surgeries that is risk is intermediate. And high risk, as I have said earlier, it is a aortic and major vascular surgeries always carries high risk. So how do you approach the patient for cardiac evaluation for non-cardiac surgery? Suppose patient, we receive the patient and there is we have a request for cardiac fitness. So first, what is the patient's risk for perioperative cardiac complication based on clinical assessment? Do the clinical assessment, see what is the risk of perioperative cardiac complication. And then after that, if the diagnostic testing is required, to supplement the clinical assessment to define and manage the risk. And after, based on this clinical assessment as well as diagnostic testing, and after doing that, then what management strategies should be implemented to reduce the risk. So patient going for surgery, there is request for fitness, then do the clinical assessment, see whether patient belongs to low risk or intermediate risk. And in addition, if required, we can go for diagnostic tests like treadmill test, echo and all. And based on that, if the risk is there, we can initiate some treatment, so that we can reduce the risk. So there are some clinical predictors of increased perioperative cardiovascular. Some predictors, like major predictors, like there is acute or recent myocardial infarction, history of recent myocardial infarction. Any history of myocardial infarction, especially within 6 months, it carries high risk. So these are some clinical predictors. Unstable or severe angina, patient ongoing pain, decompensated heart failure, high-grade AV blocks, symptomatic ventricular arrhythmia with underlying heart disease, with having structural heart disease, or supraventricular arrhythmias, and severe valvular heart disease, like especially severe aortic stenosis or severe mitral stenosis. Intermediate predictors like mild angina pectoris, history of prior MI 6 months back, or compensated heart failure, or chronic diabetes mellitus, and renal failure. It's all intermediate predictors. And some minor predictors like advanced age, or abnormal ECG, like ECG showing left ventricular hypertrophy, left bundle branch block, or these are some minor predictors. And some rhythm other than sinus. It is not sinus rhythm, some minor ECG changes like atrial fibrillation and low functional capacity, history of stroke. And these are the minor clinical predictors for the perioperative cardiac risk. And coming to assessment of functional capacity, this is very important. So when the patient comes, we can assess what is the functional capacity of that patient. that based on the MET, because actually MET means there is a there is an objective measure of energy energy expenditure for the given work. So for the patient sitting at resting, that is what you would say, the 1 MET, that is equal to 3.5 ml oxygen consumption per kilogram body weight per minute. So then suppose patient walking, the more METs required, more energy is required. So that is what we call, that is the functional capacity or exercise capacity of that for that work, for that activity. So we can calculate that MET, and based on that we can see, we can assess what is the functional capacity of that patient. So if it is 1 MET means it is actually resting, or it may be eating or dressing, using the toilet, walking indoor, and walking on level ground at 2 miles per hour. So minimal activities. And 4 METs means actually climbing a flight of stairs, walk on level ground at the 4 miles per hour the speed, and running for short distance, lifting heavy furniture. And these are some requests 4 METs. So suppose patient can do that, we can assess his functional capacity is okay, it's good. So that we can send him for surgery without much investigation. Then 10 METs means his functional capacity is good, perfect, it is excellent. So like he can swim, he can play tennis, can do basketball, skiing, and also he can run. So that means his functional capacity is very good. That patient is going for some surgery, he may not require cardiac evaluation because functional capacity, because he can do activities which requires more than 10 minutes. So functional capacity we can assess based on the clinical assessment. We can ask the questions: can you run? Can you do this activity? Can you do that? Like, so that we can assess the functional capacity. So if can you take care of yourself, and you can use the toilet, you can walk indoors, because that varies from 1 MET to 4 MET. And if you can ask, can you climb 2 flights of stairs? Can you run? Can you play like that? And then it carries up to 10 METs. So you can, less than 4 METs means it is functional capacity less. And more than 4 METs means it's okay, reasonable, and it's okay, good. So that we can send him for surgery without much risk. Then how do you do the preoperative cardiac risk assessment? Actually, we have so many risk scores, whereas various risk index scores we can use. The Goldman's cardiac risk index is a very old one. So like various factors like presence of raised JVP, left ventricular third sound, history of recent myocardial infarction, abnormal rhythm, and more than 5 premature ventricular contractions, elderly patients, more than 70 years, emergencies. These are some factors. So the points are given for each factor, and we can calculate the total points. And so we can interpret the score based on the Goldman cardiac index. Like if points are 0 to 5, risk is only 1% for cardiac complication. If it is more than 26, it is risk is 78%. So the whole score, the Goldman. And we have Detsky cardiac index, risk index, like again, various parameters like age of the patient, history of myocardial infarction within 6 months or beyond 6 months, and what is angina status, and then history of unstable angina, and then history of recent acute pulmonary edema, like various factors, again, points are given. So we can calculate, and if the points are 0 to 15, it's very low risk. So that we can say that patient carries very low risk. And if it is 20 to 30, it is moderate risk, and more than 31 is high risk. So this is another risk index score, and which commonly we use we have the revised cardiac RCRI, that is the revised cardiac risk index. We actually follow this risk index score. So 6 independent predictors. In RCI only is very easy. So only 6 factors. Like whether surgery is high risk. So high risk surgery, 1 point. History of ischemic heart disease, 1 point. History of congestive heart failure, 1 point. History of CVA, 1 point. And insulin-dependent diabetes mellitus. And renal failure, that is creatinine more than 2. So each point is 1 point. So you can look for, if there is only 0 points, there is no any these variables, then 0 points, risk is very low. Patient belongs to very low risk, then risk of complication is 0.4%. And if it is 1 point, any one of these variables are present, it is 0.9% risk of complication, though then it belongs to low risk group. If it is 2, it is a moderate, and more than 3 is high risk group. So we can stratify the patient. So patient coming with, we can look for these factors, like whether patient go for high risk surgery, any history of CVA, history of heart failure, like that we can ask. Then if based on that, we can stratify, if belongs to low risk group, belongs to very low, moderate risk, or it belongs to high risk group. You can write like that. This patient had this much, these are factors are there. This patient belongs to, there is chance of moderate risk of cardiac complication after surgery. So this is another ACS, that American College of Surgeons, NSQIP surgical risk calculator. We have an app is there. We can calculate so many points, around 21 variables are there, and based on it we can calculate what is the surgical risk, and this also we can follow. So based on this, then one algorithm for assessing the preoperative cardiac risk, like patient we can, if the RCI points are there, or NSQIP calculator, and if it is more than 1%. It is not there, straight away you can send for surgery, because there is no any RCA factors, and that MICA score is less than 1%. But if there is, then assess the functional capacity. So RCA factors are there, and which I have discussed. Then this nice QIP MICA calculator is more. Then assess the functional capacity, which we can, I have discussed that. We can ask for the history and assess the functional capacity. And if it is more than 4 minutes, then okay, then still we can send for surgery. Investigation may not be required, but it is less, actually less than 4 minutes. And there is, then we can determine whether stress test result will change the management. Then we can think of doing treadmill test. Like if it changes the management, like will result in affect the decision to perform surgery, changes the medical management, or lead to invasive cardiac procedure. Think of if there are these factors are there, medicine functional capacity less, then we go for think of treadmill test. We can assess the send the patient for exercise stress test, and based on that we can either modify the, or we can ask the surgeon to delay the surgery if the stress test is positive. Or consider initiating some treatment like beta blockers, or we can go for angiogram and assess the what is the patient's cardiac status, and then we can plan the surgery. Again, one more algorithm is 7 steps of evaluation. Like this again very busy slide. Actually, patient is scheduled for surgery with the non-case of CAD. Already there is history of CAD. Maybe prior history of myocardial infarction, or patient having angina and all. Then if surgery is emergency, straight away, emergency surgery, we have to, it's definitely high risk, but we have to send him for surgery. So straight away we can send the patient for surgery. If the surgery is not emergency, then step 2 is, if there is history of evidence of acute coronary syndrome, patients having rest pain, evidence of acute coronary syndrome, then evaluate the patient. Definitely evaluate and start treatment based on guidelines. And after that, estimated perioperative, if there is no acute evidence of acute coronary syndrome, there is estimated perioperative risk of MACE is based on various cardiac, which I have discussed. And if it is, then it belongs to low risk, less than 1%, which I have discussed all various risk scores, and we calculate. And if it belongs to low risk, no further testing is required. It's very low risk, less than 1% risk of complication, you can straight away send in for surgery. If the estimated risk is, the risk is more than 1%, that is more, then we can assess what is the functional capacity. Like if it is more than 4 minutes, then yeah, definitely if it is excellent, more than 10 minutes, straight away surgery, because excellent functional capacity. If it is a 4 to 10, again, surgery further test may not be required. If it is less than 4 minutes, then we think of doing treadmill test and other function, assessing the patient's cardiac ischemic status. Like we can either go for stress test or exercise treadmill test or pharmacological test and all. And based on that, we have to plan. If there is any evidence of ischemia, then we have to plan angiogram for the revascularization. Then supplemental preoperative evaluation, like in addition to our clinical assessment, risk stratification and all, some investigation may be required sometimes. So what are the investigation recommendation? What guideline says? Because for ECG, that function, that is class 1 recommendation is if the preoperative ECG is recommended for patients who have risk factors and scheduled for intermediate or high risk surgery. But in our practice, we are doing ECG for all. But it may be because it's not a very, it's a common investigation. But usual recommendation is patient going for intermediate high risk surgery and already he has risk factor, definitely ECG is required. And preoperative ECG should be considered for patients who have risk factors and scheduled for risk. So low risk surgery, but he has risk factors. Then definitely you have to evaluate. So risk factors, since any evidence of risk factors, you do the ECG and further investigations. One more thing, because is preoperative ECG not recommended for patients who have no risk factors and scheduled for low risk surgery? Because I have discussed so many surgery which belongs to low risk. That case, even there is no any risk factor, young patient, no risk factors, then straight away we can send him for. So ECG also may not be required, that based on the guidelines. What about echocardiogram? Echocardiogram also there is echocardiogram for assessment of LV function should be considered in patient undergoing high risk surgery. Any high risk surgery, we can do the echocardiogram and look for what is the ejection fraction. And routine echo is for LV asymptomatic patient is not recommended. For asymptomatic patient belongs to good functional capacity, there is patient low risk status. Definitely echo also may not be required. Then treadmill test also similarly, if recommended, if for patient going high risk surgery and having multiple risk factors. Patient is still smoking, the male patient is still smoking, is diabetic and his lipid level is very high. Then definitely he has multiple risk factors. Then we can assess and do the treadmill and assess the risk status. But in low risk surgery, there is no risk factors. Treadmill is not required. Then coming to angiogram, there is invasive assessment of cardiac status. We can preoperative angio. If there is evidence of STEMI or patient having history of prolonged cardiac pain, evidence of definitely angiogram is required. The function there is that class 1 recommendation. Then patient having evidence of N-acceleration myocardial infarction, ongoing pain, rest pain, and definitely required. And patient getting medical treatment despite maximum treatment is having the angina, definitely we have to do the angiogram. These are the class 1 recommendation for coronary angiogram in patient going for non-cardiac surgery. And preoperative angiogram when we consider in cardiac stable patient but high risk surgery. Patient is stable but high risk surgery again, but it is only class 2B recommendation. And routine angiogram is not at all. We are also not doing. And if patient low risk and there is stable patient, we are routine angiogram is not at all required. Then coming to last few slides, like how do perioperative as well as preoperative medical therapy. So if you start some treatment, whether can we reduce the risk status of patients? Some treatment, some trials are there, especially beta blockers, statins, and aspirins. They have tried in many trials. And so coming to that, the beta blockers, the one drug. If you start, even though there is no class 1 recommendation, class 2B recommendation is that some trials, especially POISE-1 and POISE-2 trial has shown that 8,000 patients were included in that study. So beta blocker has shown that they reduces the cardiac risk status and the complications are less with patients who have received beta blockers. So some trials there are so actually favored there is reduction in the myocardial infarction at the end of 6 months. So there is and mortality there was much difference. This is a POISE-1 is a major trial. It's 8,000 patients per trial. So these are some trials that have shown beta blocker using a beta blocker prior to surgery, giving a beta blocker some if it is not emergency surgery, giving beta blocker for some time, and so maybe try. Statins also there is class 1 recommendation, especially for patient history of myocardial infarction, history of CAD patient we can try with statins. And aspirin also, but class 2A recommendation, especially patient who is having history of evidence of myocardial infarction or evidence of myocardial ischemia, can try. These are the few drugs, whether there are no major drugs, these are few drugs we can try for reducing the cardiac risk for patient going for surgery. So these are again some various drugs we can, especially in these beta blockers, they have mentioned, beta blockers we can try. Anti-arrhythmic, some tries beta blockers, already on beta blocker, we should not stop, we should continue. But we should be careful that you should not start the beta blocker on the day of surgery. That is very important. So patient all getting beta blocker, continue the beta blocker. For BP is on lower side, we can stop it and we can reduce the dose, but we should not start the beta blocker on the day of surgery. So it is actually contraindicated. So cardiac intervention and non-cardiac surgery, last 2 slides. So actually, some recommendation like patient cardiac interventions, like patient going for angioplasty or surgery, bypass surgery, whether it is required or not. So coronary revascularization before non-cardiac surgery useful in patient with stable angina. We have significant left main, because after doing angiogram shows significant critical left main lesion, and then definitely he has to undergo intervention, and you have to do the angioplasty or surgery. Revascularization is required. And also revascularization before non-cardiac surgery useful in patient stable angina who has multi-vessel disease. If the patient has triple vessel disease, and definitely you have to go for revascularization prior to surgery. But again, we have to again weigh the risk of surgery as well as patient's risk, because sometimes patient may be requiring early surgery. Then we have to see. Because once we start do the angioplasty, then we cannot stop the antiplatelets. Then we have to wait at least for 6 months. So that we have to we can discuss with surgeons, and whether surgery is very important, or we can ask whether we can just prolong the surgery at least for 6 months like that. Again, if there is a patient has two vessel disease, but if there is a proximal LAD lesion, after angio shows proximal type lesion, definitely there is we have to do intervention, because sometimes patient can develop myocardial infarction, and it can develop some complications. Again, high risk unstable angina, patient evidence of STL myocardial infarction, definitely angiogram and angioplasty is definitely required. And also in acute STEMI, definitely no doubt, he has to go for angioplasty. And again, it's not recommended that routine coronary revascularization is not recommended in stable patient. Patient can go for surgery. You can start medical treatment. Just stop the antiplatelets prior to surgery. Let him do after that. Assess the patient once again. Then we can go for this. But if the patient is stable, then definitely we can wait for the intervention. And again, coming to the whether already undergone angioplasty, then how do you stop antiplatelets prior to surgery? That is also very because sometimes we have to stop because patient may require emergency surgery like that. That depends on what is the whether patient and received bare metal stent or drug-eluting. Because nowadays we are not using bare metal stent. It's actually out of our shelf, and so commonly we are using only drug-eluting stent. So that is the problem, because if the bare metal stent, we can stop the even within 1 month. After doing angioplasty, after 1 month, we can stop, because there is no risk of stent thrombus. But drug-eluting stents, that definitely at least 6 months are required. We cannot stop the antiplatelets up to 6 months. So that is the problem. So the patient, yes, earlier we were using bare metal stent, but nowadays only drug-eluting stent. So patient are undergone drug-eluting stent, then depending on the days, like this, this algorithm received, and he is on dual antiplatelet agents. So after 3 months, after that, you see within 3 months, definitely it is very risky to stop. If it is a very emergency surgery, then we have to take go for surgery. But otherwise, at least we have to wait for 6 months. And after that, we can stop antiplatelets. If there is no ongoing ischemic study, no ongoing pain, patient is clinically stable, we can stop and can send him for surgery. That's just a recommendation on anesthesia, because I cannot talk on anesthesia, but as anesthesiologists, they have to decide. So like some points, like consideration should be given to perform thoracic epidural anesthesia instead of general anesthesia in high-risk surgery with cardiac disease. So patient with cardiac disease going for IVC, they can consider doing epidural anesthesia instead of general anesthesia. And also NSAID should be avoided in patients with having heart disease, especially heart failure patient. And all. For pain management, NSAID should be avoided, especially if there is renal failure, heart failure, or myocardial ischemia. Thank you for your patience.
Right. Thank you, Dr. The excellent instrumental on preoperative cardiac evaluation for non-cardiac surgery. The topic is open for discussion. I want to know two things. First is how reliable is the instant platform? Reason is that while some quite often it could be around 60%, but the opinion there would be like IHD, RWMA, then national dysfunction, one EPP, two ways of predictive previous history of the and second thing is that however
that we see the risk and we think the cardiac stack is not we can help competition again or nothing because we hope it is difficult to almost almost 40 patients in for the but especially for most of the patients are for cardiac weakness. Reliability of working very actually rejection fraction reliability is actually assessment of this. Yes, we don't. I don't get that percentage. This is our assessment. If definitely the more than 60% are very questioning how much rejection fraction is normal.
I just want to know that
One the report report assessment we are seeing methods are there to assess and if it is the more than more than 50%, actually everything is good. This is borderline that we around 50, 55, and around some machine. So we mentioned that in this machine like that. After going my number, I actually assist the whole question. Based on that, we have not only that rejection fraction, not that nothing important because in all languages, the functional capacity for surgery, the functional capacity good, and definitely that the assessment of that rejection fraction also not required.
based on one week time. Union around Monday and creating Monday. Here's what I offered in Europe and here's the Eastern. Certain the patient whose urea is 1 day and creatinine 5.1, who had the ACS 1 week back, has to undergo a stenting. Only then the obstructive uropathy will go and he can be taken up for angiogram. How to go? I think the creatinine is raised because of that obstructive uropathy. I think that better relieve that obstruction and it will become normal. But even he had ACS 1 week back. Then again, if the ACS is with unstable patient, then you have to stabilize the patient first. We have to optimize. How to optimize? That's true. See, is cardiac disease how to optimize the cardiac series? Acute syndrome is actually evidence of acute syndrome, evidence of NSP exactly science. We have to stabilize the patient with the antibiotics, statins, hydrostatins, then they get started with the patient stabilized. Now, we talk in ongoing pain, if there is history now other other changes, enzymes are not they are become normal. Then if the strengthening is then because it is an obstructive Because creatinine spraying, we can't do the angio. Angiogram is not possible because of the risk we have. Because we are waiting with it because now, usually like that. If the patient changes also, if the patient symptomatic is stable, like there is no ongoing pain, that's normal, then it's normal. Then we can wait. So in this case, I stabilize the patient, wait for 1 or 2 weeks, then send it for distance sending, so that we have become normal. Once sending, I know that will become normal. Then we wait for 1 or 2 weeks. After he has got obstructive urology, he can go to urology. So we get this life treatment. How can he wait for 1 or 2 weeks? And then depending on the patient, this is really this one. ACL patient, we can reduce services. ACL treatment is but he is having obstructive urology. Yeah, that's right. Once we can go for stability. Then if he is having obstructive urology, he will go for and if you have to go for standing at the same time, you can give our a patient was on who's on antiplatelets and all. He is coming for, he is giving a dual option. Whether you want to go for TU or neural system of conflict, or you want to go for laser. Laser possibility is expensive. He opts for TU or go. Because we will land up in the backwards. This application is having AC. No, this is a different way. This is the second thing I am saying. A patient who has undergone DVR or AVR or surgery is coming out in the bigger prospect. We give an option for TORP or laser. He is not waiting for laser. He wants TORP. How to go? Clearly, you are that all time you has to stop because you can't do shopping. So in this case, it's actually not applicable to any survey having undergone WR or AVR or medical replacement. There is a research treatment guidance something because patient requires surgery. Usually that way, again that patient stop the organ, we stop organ violence, check the identity. Okay, then at the same time we cover with apparent. So it has to be hospitalized, start injection apparent, stop the organ violence, check the identity, send it for surgery. Part of the surgery. Then again after surgery, after 1 or 2 days of incident, you can keep hospital. That day of surgery, stop the apparent, or 1 day prior, I think we can stop the apparent. After surgery, after 1 surgery, we restart the apparent. After 1 or 2 days, you are something sometimes difficult because bleeding is there. And we restart online environment. Then stabilize on higher more than 2 months after resetting. I disagree because it is very difficult to stop apparent or anticoagulants if the patient is undergoing PR. Even a normal patient who undergoes PR, he can land up with bleeding, he can land up with clots, and you have to do a clot vacuum. Yeah, that's why I was saying moment, but you have been usually always very difficult because bleeding is small, bleeding is patient ongoing. But if you have for these places, do you have any carrying on this? You got to check the patient as a whole. Because if you go stop this antibiotic, online model, we never keep the 1 or 10 feedback. So you have to weigh the risk and plan management. So the common problem we face, you have to weigh which is the more patient risk of surgery and patient. That's why in private practice, the inverted comma, how to go around. That's a if no one questions.